it blurry? No? Okay. All right, so these are my disclosures. And Genzyme Corporation did fund the pilot research, which I'm going to mention here next. In terms of background and significance, I mean, I think most people know in this room that respiratory muscle weakness remains a big clinical challenge in late-onset Pompe disease, and it's the primary cause of morbidity and mortality. Certainly, enzyme replacement therapy has been a real game changer, but the effects of ERT on respiratory strength are pretty modest. So we have data showing that there's small strength increases present in about 2/3 of patients. These effects seem to peak relatively quickly after the initiation of treatment, 12 to 26 weeks or so, and then diminish over time. So mostly ERT tends to slow respiratory muscle decline over time. There's more recent data showing that although ERT reduces the likelihood of wheelchair dependency, it does not do so for respiratory support. So, this remains a clinical challenge, and in response, we have developed an intensive 12-week respiratory muscle training program. We use calibrated, individualized, progressive resistance, targeting the inspiratory and expiratory muscles to see what effects we might be able to induce there. We first studied this in 2 patients, just a case study. It seemed as if respiratory muscle training was safe, well tolerated. There appeared to be strength increases as a result, and we then completed this regimen in 8 LOPD subjects using a single subject experimental design, multiple replications across those participants, and we found that RMT seemed to be safe, feasible, well tolerated. We saw large to very large increases in inspiratory and expiratory muscle strength and response. As an example, the maximum inspiratory pressure, an index of inspiratory muscle strength, increased by about 19.5% across those participants. And additionally, after we stopped training, so they trained for 12 weeks, and then they detrained for 3 months, those strength increases were relatively persistent. We didn't see much of a drop-off, somewhat surprisingly, over those 3 months. Since that time, other groups have reported on the effects of respiratory muscle training in LOPD and have generally had fairly similar results in terms of the magnitude of effects, and safety and tolerability and things like that. So accumulating data suggesting benefits here. So we then wrote a grant to NIH NIAMS to conduct an exploratory double-blind RCT of RMT and LOPD. And so this involved random assignment to either treatment or control. In this case, the treatment was, again, respiratory muscle training, and they were training at 60 to 70% of their max. And in the control group, they were performing sham-RMT, so this was at about 15% of their max. This was, again, the 12-week regimen. During this time, they completed 75 inspiratory repetitions, 75 expiratory repetitions 5 times a week. Over those 12 weeks, that's a total of 4,500 inspiratory, 4,500 expiratory repetitions, so fairly intensive. The primary outcome measure was maximum inspiratory pressure, or MIP. Again, this is a volitional measure of maximal inspiratory force, maximal inspiratory strength. Secondary outcomes included maximum expiratory pressure, which is the similar measure for the expiratory muscles, 6-minute walk test, gait, stairs, Gower's chair, scale, peak cough flow, RPAC scale. And our exploratory outcomes, we looked at an overnight sleep study at pre-test and post-test, so polysomnography outcomes, diaphragm ultrasound measures, and then some patient-reported outcomes of fatigue, the fatigue severity scale, daytime sleepiness, Epworth Sleepiness Scale, and sleep quality with the PSQI. This is an overview of the study. I think the thing to note here is that there's a fairly substantial burden for participation for our subjects. So this was 9 visits over 9 months. Most of those occurred during the first 3 months during the active phase of the study. But again, it was a fairly robust commitment from our participants. And so here are some of our results. In terms of enrollment, our goal was to enroll 28 subjects, and we were able to achieve that. We had 6 withdrawals before starting study procedures, but we were really hoping to have 10 to 12 subjects per group, and so we were able to do that. We had a total of 22 subjects were then randomized to either RMT or sham-RMT, so 12 in the treatment group and 10 in the control group. Despite randomization, there were differences in our subjects at baseline. So the RMT subjects compared to the control subjects, they were older. They had been on enzyme replacement therapy longer by about twofold duration, and had increased respiratory muscle involvement compared to the sham-RMT participants. So their FVC, upright and supine, MIP and MEP, those kind of values were all diminished in comparison to the control group. Adherence, again, it was fairly intensive. We monitored adherence with a device we developed that would quantify adherence, so we didn't have to use patient, logs, which are prone to error. And the adherence rate was really high in both the treatment group and the control group. So in terms of our respiratory muscle strength outcomes, our primary outcome was pre-test to post-test change in MIP, maximum inspiratory pressure. And we found that MIP increased 7.6 centimeters of water pressure in the RMT group compared to 2.7 centimeters of water pressure in the sham-RMT group. So about a 17.2% difference in the RMT group versus a little bit over a 4% increase in the sham group. These results were not statistically significant, and that's at least partly explained by those real large standard deviations that are shown there. We found similar results for the pre-test to post-test change in maximum expiratory pressure. We found that increased about 14 centimeters of water pressure in the RMT group, about a 23% increase, and there was no change in the sham-RMT group. Again, though, did not achieve statistical significance, and you can see those large standard deviations for both of those groups there. We did not detect statistical significance for our other secondary and exploratory outcomes either, except for patient-reported daytime sleepiness with the Epworth Sleepiness Scale, which was improved in the treatment group relative to the control. So, a big part of this study was to assess how useful sham-RMT was as a control condition. And so I would say the first thing we learned was that sham-RMT definitely facilitated our double-blind RCT. There was really no evidence that researchers or subjects penetrated the blind. Research participation across the groups was very similar. 20 of 22 subjects completed all study visits. And again, adherence rates were high in both study arms. So they had very similar experiences throughout their participation in terms of doing the activity for the same amount of time. They saw the RMT clinicians for their therapy visits the same amount. They had the same phone checks and things like that. And it did appear to facilitate the double-blind study. All the researchers except for the RMT clinician were blinded, and the participants were blinded too. However, and this is pretty important, I think, sham-RMT did not appear to be inert. So it appeared to be an active treatment, in other words. When we think about a sham control, we can think about, it's our attempt to use like a sugar pill, a placebo pill. But in many ways, it's difficult to design behavioral interventions that are similar to the active treatment and believable, that are omitting the key therapeutic element or ingredient. So we train them at a really low amount of resistance. And that's been shown to be an inactive control in other patient populations, but it didn't appear to be so in this group. And talking to other people, even with no resistance, which might not facilitate the blind so well, that could still be like a deep breathing activity, could still be an active treatment. And a deep breathing treatment would be manifestly different than the respiratory muscle training. So a lot of challenges, I think, in control conditions for these type of interventions. Overall, though, again, we found the magnitude of change to be pretty modest, but still greater than we expected. So, and the amount of variability across participants in the sham group, again, greater than expected. So these had a negative outcome, a negative effect on our ability to detect differences between the groups. And again, it appeared to be an active treatment. It might not be the best control condition moving forward. So, we learned a lot of valuable lessons during the study, and foremost among these is that LOPD participants are really motivated for clinically relevant research participation. We had participants come from all over the United States. We're in Durham, North Carolina. We had people from Texas, Florida, Maine, West Coast come to Duke for 9 visits. And we only had 2 dropouts. 2 people that did not complete all study visits. So really a highly motivated group of patients. We tried to provide good reimbursement, but it probably was a little bit suboptimal too. So again, people really responded and showed up for the research. We found no serious adverse events related to RMT, which again suggests this is safe, well tolerated. These next 3 that I bolded here, I think they're our main explanatory, our main explanation for our lack of significance. So again, the magnitude of change in maximum inspiratory pressure was very consistent with what we saw in our pilot work, but the variability was greatly increased. So really lost a lot of our signal there. Similarly, sham-RMT appeared to facilitate our ability to do a double-blind RCT, but it appeared to be an active treatment and not inert, so perhaps not the best control condition, really. And again, despite randomization, there were baseline differences between groups in terms of their characteristics, and the RMT participants were generally older, had been on enzyme replacement therapy longer, and had increased respiratory muscle involvement. We had considered carefully as to whether or not we should stratify participants. We were concerned that might affect our ability to recruit and enroll. In retrospect, I guess we should have, okay, lost my, anyway. We also found that polysomnography, our sleep study outcomes, weren't very helpful, nor were the diaphragm ultrasound measures. The overnight sleep studies were very burdensome for participants. And many participants couldn't complete any of the study without support. And so it was hard to get meaningful data, a lot of subject burden, and a fairly substantial research costs too. So we wouldn't include those things moving forward. Overall, we'd suggest that further study is needed of RMT and LOPD with a larger sample size and a multi-site trial. So that's what we're planning now. In yellow here, we have the R21 exploratory trial, which I just shared the results with. We are submitting next week, it's being internally reviewed now, an R34 planning grant to NIH NIAMS. And this provides 2 years of planning support to develop the infrastructure for a future 5-year U01 clinical trial implementation cooperative agreement, as titled by NIH, which would be like an R01, a multi-site trial to further study RMT and LOPD. So that's where we're hoping to move forward with this. We had submitted the R34 last year, and it was fairly well received even though we didn't have data, which was the main criticism, pretty valid. We carefully are considering the control condition for this future trial. I think this ultimately boils down to the sham RMT versus like a no treatment waiting period control. Certainly the benefit of the sham is that this enables blinding to allocation and allows us to conduct a double-blind RCT, which is definitely the gold standard for research. I think, though, that we might need to look past that typical design, though, in this case, in this population, in order to get the work done. And I think there's some real advantages. And some real cons to the sham. Again, it's not inert. It was active. We thought it might have negatively affected our ability to deliver RMT to have the sham group. We spent a lot of time making sure that all the participants were equally treated and got the same feedback, and it might have undercut our ability to provide useful feedback to participants. And our patient advisory committee members, they noted that RMT is increasingly available clinically, and that having a sham might limit recruitment, enrollment, and retainment in a future study. And we also thought it might be difficult to do the sham across multiple sites. I think there's some real advantages to a no treatment waiting period control in this instance. Allows each subject to serve as their own control. This would enhance recruitment, enrollment, retainment compared to use of a sham, and certainly decreases the sample size needed in compared to a 2-arm study. Additionally, we wouldn't have to worry so much about the equivalency between groups. And importantly, if we don't have a sham control, we could really deliver much of this by telehealth visits, certainly the RMT therapy visits, and do those by telehealth and really reduce the amount of subject burden for participation. So, and that was recommended by our patient advisory committee again. And we could deliver this more consistency, improve the consistency of delivery across sites. So that's our argument for the future trial. In summary, I would say that RMT continues to show promise as a treatment for respiratory muscle weakness and LOPD. We are proposing a future multi-site clinical trial with a no treatment waiting period control, and our power analysis suggests we need 82 subjects. That's very conservatively powered. Kind of worst case scenario for every thing we can control, and that would include a 20% dropout rate. This was informed by our very helpful patient advisory committee. Once again, they participated in the R21, R34, and moving forward. So I was glad, especially with these talks today and last night, that I had done this and not, gone off on my own. But they've certainly been very helpful. We could use telehealth visits to allow delivery of RMT and reduce the participant burden. And then really, our plan is to submit this R34 planning grant and hopefully have that lead into a U01 clinical trial involving other sites. I'd like to acknowledge NIH NIAMS, the Patient Advisory Committee, my research collaborators, and certainly the past and future research participants and their families.